get that perception from the person. So is person report of exhaustion or lack of energy. So, but then whether it is in disease condition or in health, whenever fatigue sets in, it leads to a reduced capacity to perform physical or mental activity. But the only thing is that in healthy individuals is temporary and you can predict it. Maybe there's a level of work that you know when you do, you get fagged out and tired. Of course, it's related to exertion when you have a lot of physical exertion and physical activity. But then one thing is that when you rest, you now regain yourself and recover from that fatigue. That means fatigue is protective. So that you don't do exertion that may lead to injury or harm to the tissues of the body. So that is just like pain is protective, So, but cancer related fatigue is now persistent. Of course, also subjective to sense of it's also subjective. You understand? It's a persistent fatigue that is there, whether you rest or you don't rest. The thing is that it's stressing and persistent, and it's patient that tells you that it is there. And when patient now reports it, not only physical, emotional, or cognitive tiredness or exertion related to cancer or cancer treatment, but now in health, it can just be related to physical activity or exertion. But in disease, in cancer, is as a result of cancer or cancer treatment. We know that is when I was diagnosed as cancer, it's as a result of cancer progression of the disease or the treatment that caused this fatigue, which is not proportional to activity. So you must not engage in activity for you to get fatigue, even at baseline level. At rest, the fatigue is there. It's not only that it's there. The one thing is that interferes with usual functioning and not really by rest. So it's not only that you're weak, but you are weak to the extent that you cannot even perform simple activities of daily living, even when you are resting. So, but one thing is this that we may not let us not think that fatigue, have will necessarily correlate with tumor stage. Maybe say stage 3 cancer, stage 4 cancer, the person should feel more fatigue than stage 2 cancer. No, it's not always like that. So sometimes we may see patient with early stage disease that may experience severe cancer, whereas people that are with advanced cancer or diseases may report relatively lower fatigue levels. So that's why I say it's subjective. It's the energy level that the patient tests so that he has or he feels. That is what you should take. So when you now bring it to 4 again, comparing two of them so that we also understand it more, even though most of, we know what is fatigue as far as we're physical, but let's just bring it clearer to the context of what you are doing. Related activity in normal fatigue, but then may not occur may occur without activity. That's in cancer. So when it is normal in a healthy individual, it improves with sleep, but in cancer, it persists despite adequate rest or sleep. It does not relieve it. So it's short-lived in normal individual because if you just take a little rest, you recover. But it can only increase or extend in or exacerbate in cancer unless the cycle is broken down. Intervention is given. It lasts for weeks. You're looking at weeks, it enters months, and even years. So it can just be a mild to moderate, but then it can progress often to severe fatigue in cancer. You can predict it in terms of any activity load that you may do and you get fatigue. But then in cancer, it's variable, it fluctuates, and it's unpredictable. So it limited effect on activities of daily living, but significantly impairs daily activities in cancer. A normal individual, it has limited effect. Maybe as of that time, you're just fatigued, the rest you just recover. But it's something that stays and progresses, and there's now functional decline to the extent of affecting activity of daily living. And of course, we talked about fatigue. It's just a physiological process, maybe energy depletion or the action potential and acting medicine, filament theory, disruption, dysfunction, motor dysfunction at that physiological level. But then in cancer, it's multifactorial pathological condition that a lot of factor causes it. It can be physiological. It can be as a result of treatment. It can be as a result of the cancer progression itself and other psychological issue can also lead to that. So, when you rest, you recover in normal individuals, but in cancer, you rest and the fatigue gets worse, according to research. Of course, there's how we broke down the epidemiology, that the prevalence of it. Of course, we know that it's most frequent a symptom in cancer, follows by pain, and then others, breathlessness, and other symptom that needs relief. So before treatment, a diagnosis or treatment, pre-treatment research has shown that 30 to 60% of individuals come down with fatigue already. Then during chemotherapy, 60 to 90% of people who undergo chemotherapy come down with chemotherapy, cancer-related fatigue, or radiotherapy, 70 to 100% of them who do. You can imagine when somebody now did combine chemotherapy and radiotherapy. So during cancer survivorship, when people have done this is during active treatment, during chemotherapy and during radiotherapy. Then after they have completed your treatment, be it surgery, chemo, radio, when we talk about survivorship, when there's a prognostication that people may live just 1 year, 6 months, so on and so forth, just months to years after treatment, it comes down a bit, 30 to 40% of the individuals. But when cancer has metastasized, so advanced cancer, you have more than 80% prevalence. And this is the one that is most usually quoted in literature. So cancer-related fatigue is highly prevalent and across the cancer continuum, especially during active treatment and in advanced diseases. So the epidemiology continues. So these are the common kinds of cancer where CRF, cancer-related fatigue, is prevalent. It occurs in other cancer types like cervical cancer, so on and so forth. But these are the main one: breast cancer, lung cancer, colorectal, prostate, leukemia. Of course, that is blood and bone marrow, lymphoma, of course, lymph node, multiple myeloma, bone, then head and neck cancer. So it varies according to cancer type, that's cancer-related fatigue, the treatment modality that's used, disease stage, of course, and then in case if it's advanced and metastasized, an assessment instrument that you used in it. So why do we talk about it? Of course, we say it's multifactorial. It affects many aspects of health domains, like the physical, psychological, social, and cognitive domains of health. And when you're talking about physical, psychological, social, and cognitive, you're talking about quality of life, because quality of life, encompasses all these domains. So if cancer-related fatigue, we may be looking at it, just as a physical symptom, but you can see that it affects all the aspects of health that can impair or make the quality of life not to be good. So it's a serious issue. So in the physical aspects, when you see muscle weakness, reduced endurance, exercise intolerance, fall risk in elderly persons because sometimes there's imbalanced issues and the functional decline. Of course, cognition. We have what we call chemo brain. Happens especially people who undergo chemo. So these symptoms, group of symptoms, are called chemo brain. When somebody is undergoing chemotherapy, poor concentration, person has poor concentration, memory impairment, reduced attention, slower information processing. You can see that these cognitive issues may sometimes even be of more concern to the patient than the physical weakness that that the person may be experiencing. Imagine a student or a business person who is always calculating money, say a petty businessman, businesswoman who always gives change and collects money, gives change in coins and some other, try to calculate this. It will slow down all these things. Sometimes they even lose their jobs, or they cannot, they incur losses, or they cannot cope with that demand of intellectual work and energy demand, and they close down their shop. These things are evident in our clinical settings from our researches. So you can see psychological affectation, anxiety, depression, emotional distress, and reduce motivation. So you can now see reduced work productivity, as I mentioned before, social isolation, financial burden, and loss of independence, because there may be social activity because the person has not got strength to even compete and relax, and psychological issue can also bring about isolation, financial burden that is also the person incurs, loss of productivity, loss of job, not being able to meet up with work demand, and also all sorts of that. Before you know it, the family social, psychosocial relationship and family communication breaks down, especially when the person is the breadwinner or dependent on the breadwinner who may not understand because of the financial burden and the burden of care, caregiver fatigue and all those things. So it's a multidimensional symptoms, cancer-related fatigue, that affect the physical, social, cognitive, and social well-being. And the ultimate aim that cancer-related fatigue affects and reduces the quality of life. Of course, we have to look at international classification for functional and disability, because as physiotherapy, this is very, very important. We have to put it in this context. So that is why we have to get attention from the policymakers. If we don't put it in this context, we may not get attention from policymakers. Of course, this is also part of the theories that drove the rehabilitation 2030. Of course, cancer-related fatigue impact on functioning through the ICF model. You look at body structures now. Of course, you can see there's muscle weakness, reduced aerobic capacity, and sleep disturbances. And when the muscles are weak, there is reduced aerobic capacity. Of course, you know that oxygen is needed for metabolism and for release of ATP, which is the energy that body needs to function. And there's reduced aerobic capacity, that's VO2 mass. Maximum oxygen consumption is reduced. That means the energy demand will also reduce because no enough oxygen molecule won't be entering the metabolic cycle for metabolic breakdown to release ATP, which the body needs for activity. Then sleep disturbances, of course, you see this. And when it is, so these are impairments on the body function structures, which will lead to limitation in what the individual can do. The individual will not have the energy or the power in the muscle, the endurance to do what it's supposed to do, and that leads to activity limitation. So activity limitation, as simple as walking, can be laborious in cancer. People living with cancer who are having fatigue, even as little as climbing the stair, can be laborious. Lifting and self-care, it's a big issue if you have practiced in a cancer setting. So when you now say activity limitation, limitation in activities will result in reduced participation in life situation, because these activities are what you use to carry out your life situation. Walking, stay climb, lifting, self-care, what else? You need this movement to function every day. That means if you have limitation in activity that you use to function in every life situation, that means your participation in activity will be restricted. That is where it leads to a participation restriction. Yeah, it can restrict your employment because you may not have the energy to withstand, the energy demand of that, and depending on the kind of work you do. Social participation and events, family roles, community engagement, because this kind of thing, this kind of family, the man does this, the woman does this, let this take care of is the stance of a woman who cooks, does her chores, clean the house, maybe a housewife washes the clothes of the children, and this fatigue comes in. You see the family role changes. And if the family, the caregivers do not have the adequate coping strategies to cope with this, it can bring about breakdown in family communication and the family social environment that patient needs to be broken down, and the quality of life, and that raises anxiety, depression, and before you know it, it's a vicious cycle. Then the impact of your treatment as a clinician will not make meaning to the patient, because quality of life as far as the patient is concerned is about his emotion and well-being, which that family breakdown in communication and psychosocial support has shattered. She just want that to be there. So now the family needs to know that before this woman was diagnosed of cancer, she was the wife, a housewife for that matter, with subsequent rules. But now she ceases to be a wife, but a patient within the home. So she should be cared for as a patient and given all the support that she needs. In palliative care setting, we do this kind of conference meeting with family members again. So family rules can lead to a restriction in participation with attendant frictions here and there. So this reduced participation will lead to poorer well-being and quality of life, which can now create a negative, the condition and all those things, a negative cycle, and the body structures keep being the condition and inactive, and the cycle continues. So this is according to ICF perspective. Then we have to now look at part of physiology of cancer-related fatigue, because we are scientists, we just need to know this, but I will not go in depth. Maybe when you go for your higher degree, master's, PhD, or your postgraduate clinical pathway in physiotherapy in Nigeria, NSP, that postgraduate physiotherapy college, for instance, we can now dig deep, because we also need to be researchers, because it's not only as prescribing exercise to relieve fatigue, but at molecular level, what happens at molecular level? We must be able to prove that what we are doing has effects at the molecular level, which will bring about improvements in fatigue level, in reducing the level of fatigue. That will make us to engage more in researches, and also being able to win a grant. So as clinician, we must know that that's what makes us as a scientist and differentiates us from technologies. So it's not caused by a single mechanism. It's very complicated. It's involved the tumor itself, cancer treatment, the immune system are involved, the skeletal muscle are involved, the nervous system, and behavioral factors. All these things have effect. So cancer-related fatigue does not, it's not one system event. So if you are addressing only the physical effect, you are making a good mistake and you don't recognize others, it affects others. And that's why exercise is also a powerful tool, because exercise has a mechanism affecting all these systems simultaneously at the same time. So the multifactorial model of cancer-related fatigue, the tumor, as a result of inflammation and metabolic changes, the treatment, chemotherapy, radiotherapy, and surgery, that's what they do. Muscle, the weakness and mitochondrial dysfunction in the muscle. You understand? How does it come about? Psychological, sleep disturbance, anxiety, and depression. So tumor, that the second cancer itself as a disease and its progression, the treatment effect, the muscle, the psychological. So all this is, in fact, it's a biopsychosocial. Before we were operating by medical model, but now we are operating biopsychosocial. We are not only looking at the cause of the disease and attacking it, we're also looking at other causes or other effects, like the social, the psychological, that's biopsychosocial, that's the current trend in medical practice. And cancer-related fatigue also falls because it affects all these domains of health. So let's look at, honestly, this is just, I've tried to summarize it in one page so that we won't take our time, but just to open it up to us. We may know it, but then let's know it. Even the tumor itself, we say the multifactorial, we have the tumor, we have the treatment, we have the muscle, and all that, and we look at what happens at that level just briefly before we now go to physiotherapy intervention and all of that. So tumor-induced inflammatory pathway leading to cancer-related, this is only one pathway. Tumor, this one you're seeing here is only one pathway, the tumor. So the tumor grows, the tumor cells, as it grows and infiltrates, in the environment, it leads to release of inflammatory cytokine like interleukin 1 beta, interleukin C, through tumor necrotic factor alpha. All these things are pro-inflammatory cytokines that exacerbate inflammation. In the body, which we have pointed to one of the causative factors of cancer. Because all this inflammation will release reactive oxygen species, which will damage the DNA and cause alteration in the gene, and the alter gene sequencing of those will now lead to cancer. It's one of the pathway. So now this will cause systemic inflammation, and you see that the markers of inflammation, like C-reactive proteins, will be increased. Like when you are doing exercise, one of the molecular this thing that you look at components is C-reactive protein. If it's reducing, that means the inflammatory effect of that intervention on is strong. If it is reducing, that means it's anti-inflammatory. Its effect on inflammation is good. But if it's increasing, that intervention or whatever has no effect or is exacerbating inflammation. You can now see C-reactive protein, pro-inflammatory mediators, others will write oxidative stress and immune activation. And this oxidative stress with these inflammatory substances also release reactive oxygen species, which attach the DNA and all that stuff, and they also they require high metabolic energy. So they beat down the oxygen, the carbohydrates, this thing in the body, and start attacking the protein. So that's oxidative stress we're setting. So metabolic, breaking down the protein, metabolic and physiological changes now occur. There's high energy expenditure in these inflammatory reactions, and cancer cell also require a lot of energy. So there's high energy expenditure. When these cancer cells, grow and multiply rapidly, they're highly catabolic. So they spend the energy, and of course, they feed also on carbohydrate and sugar. They break down the carbohydrate content of the body very quickly and resort to attacking the protein breakdown, which should have been for repair and growth of muscle tissue and all those things. That's why you also see cancer cachexia, because the protein that's needed for the nourishment of the muscles and maintenance of the muscles are also breaks down protein catabolism and there's muscle wasting. So it's one of the processes, that leads to cancer cachexia. Cancer cachexia is even another big topic on its own, which we may treat subsequently. Then there's other metabolism and hormonal dysfunctions. And one of the things that it is, there's early satiety and other taste and nutrition deficiency. Person won't be able to be eating enough, because when you eat little, you get satisfied, but then your body has not got it. Of course, what you see, loss of muscle mass, like in cachexia, decreased strength, impaired function, which lead to exercise intolerance. That is the fatigue you're talking about, persistent, overwhelming sense of tiredness that is not relieved by rest, and it interferes with usual functioning. And what drives this process is chronic inflammation, mitochondrial dysfunction, because this inflammation, this reactive oxygen species also attack and destroy the mitochondria. And it's the mitochondria that is where the metabolism takes place and release of ATP happens. So it has cut short gradually the mitochondrial level and the energy cycle, energy releasing cycle in the body. Can you see? So this is and muscle wasting now comes in. The energy is not there, the chronic inflammation continues, and muscle are wasted. So nothing to carry on with. The renal dysregulation also sets in. So all these things we need to exercise intolerance, which reduce to reduce physical activity and the conditioning. And the conditioning is a vicious cycle. It continues and again, and exacerbating the fatigue. So, and that fatigue, when it occurs, of course, you say it has physical components that affect the cognitive, it affects the emotional, and it affect the social, which are listed there too. So now, treatment-related mechanism. This is just in a summary that I did it. So it's more than that, but we need to know it maybe in further studies. So treatment-related mechanism contributing to cancer-related fatigue, chemotherapy, of course. Chemotherapy, apart from the cancer itself, we have inflammation, reactive oxygen species, damage DNA, damage the mitochondria. Chemotherapy brings about mitochondrial dysfunction. In fact, it damages the DNA, not even mitochondrial dysfunction. And then there's reduced ATP production because it's in the mitochondria that pyruvate enters. When you see the aerobic metabolic cycle, the pyruvate enters into the AP, is into ATP that is now broken down into the mitochondria. Pyruvate enters, glycogen, carbohydrate to glycogen, glycogen to pyruvate. Pyruvate is inside the mitochondria that it's now broken down when oxygen enters there into ATP. The ATP is free from the mitochondria. So the chemotherapy destroys the mitochondria and brings about dysfunction. And of course, what else? Reduction in energy production, anemia and impaired oxygen delivery, oxidative stress, as I've mentioned, we know what it is, and muscle protein breakdown. We can be seen cachexia, chemotherapy, peripheral neuropathy, which also alters sensation and brings weakness. So radiotherapy, local systemic inflammation, of course, we see those inflammatory reaction. We now join to the cancer, the one caused by cancer, tissue injury and repair demand, because the radiotherapy itself, who attacks and kills the cancer cells, unfortunately also kill normal tissues, also including the mitochondria, then increase metabolic energy expenditure, then also because of the inflammation and all those things, fibrosis and reduced physical function. There's fibrotic things that happens after radiotherapy that may restrict joint range of motion, especially when there's after surgery, especially in breast cancer. So surgery, post-operative pain, prolonged immobility and physical inactivity, skeletal muscle atrophy, and temporary reduction in cardiopulmonary fitness because of immobility, prolonged immobility after surgery, and monotherapy, endocrine metabolic alteration, loss of muscle mass, strength, weight changes, reduced exercise tolerance can go up or down. Then immunotherapy, immune system activation, which now lead to all those reaction inflammation. Cytokine release, it's a syndrome. When it's present, it goes to cause more inflammation. Persistent systemic inflammation, which reduces reactive oxygen species, which now, of course, I've explained what it does. So persistent tiredness, reduced physical and mental function, lower quality of life, and daily dysfunction. That is what this leads to treatment, cancer-related fatigue. So what happens at that mitochondria? So in healthy people, there's adequate ATP production. Efficient mitochondria produces enough energy to support normal cell function and physical activity. That is its work in healthy person. But in cancer and during cancer treatment, there's mitochondrial injury, chemotherapy, both chemotherapy, radiation, and cancer-related inflammation. Chemotherapy and radiation are treatment. Cancer-related inflammation is the inflammation as a result of the cancer itself and its progression. So both treatment of chemotherapy and radiotherapy and cancer itself damage mitochondria and increase oxidative stress. Oxidative stress, They now start breaking down the protein and releasing reactive oxygen species, all those radicals in the body that also sap the energy of the body and also damage the DNA. So reduce ATP means less energy. So impaired mitochondria produce less ATP, is reducing the cell's energy availability. So energy shortage, and that is exhaustion, fatigue at little activity. So no energy leads to any exhaustion at little activity, reduce endurance and increase cancer-related fatigue during daily activity. So of course, the mitochondria are the cell's powerhouse. The chemotherapy can alter it, that powerhouse, and nothing happens. Only that we have fatigue. Reduce ATP production, decrease muscle endurance and strength, increase passive fatigue, and reduce activity tolerance, and lower physical function and quality of life. These are the key consequences from the treatment of cancer. Then skeletal muscle. Muscle weakness is not simply lack of effort. It is often the result of measurable physiological changes in the muscle. So there are a lot of physiological changes that you see, but then we have to relate it to our functioning. So major changes that you see in the muscle is loss of muscle mass. Of course, when there is a protein catabolism, because of reactive oxygen species and increased inflammation, who will sap the energy stores of the body in terms of glycogen, then they will resort to break down protein catabolism, which should maintain this muscle and maintain the integrity and all those things. There's loss of muscle, cachexia, cancer cachexia. So as little as difficulty in walking and climbing stairs and walking around the house becomes an issue, clinical consequences. Reduce muscle strength, the fact then reduce clinical ability and even sit to stand and other simple things. Reduce oxidative capacity, exercise intolerance, altered muscle fiber composition, when you're losing muscle mass and every other thing, and the therapy is damaging the muscle cells and all this functional decline, increased protein breakdown, greater dependence in activities of daily living because they've stopped the energy, the major source of energy is carbohydrate, and they resorted to this protein. That's why the person keep losing weight progressively. Catch there. So psychological and sleep mechanism, sleep disturbances like difficulty falling or staying asleep, fragmented sleep, interrupted or frequent awakening during the night, non-restorative sleep leading to daytime tiredness. Psychological factors, anxiety, depression, and stress, it can lead to more release of the inflammatory mediators. So all of these will lead to reduce recovery and increase the fatigue. So research has shown that sleep disturbance and depression are among the strongest predictors of persistent cancer-related fatigue. So, of course, when all this happens, we have said this, but just to summarize it, you see the cancer and treatments. What happened? The disease itself and cancer therapy trigger multiple biological and physiological changes, which I've discussed in summary in the past slides, which will lead to fatigue, which may be physical, mental, and emotional, or tiredness, then which lead to reduced activity. When there's reduced activity and movement, musculoskeletal weakness and the condition enhanced sets in reduced use leads to loss of muscle strength, endurance, and aerobic capacity because activity has reduced and use of muscles are reduced. And overall fitness will now decline both cardiovascular and functional capacity. So it leads to more fatigue, lower fitness and strength result in increased fatigue, restarting the cycle again. So it's a vicious cycle. So cancer and cancer treatment, it's just in a summary that I'm now doing. So, chronic inflammation, mitochondrial dysfunction, oxidative distress, muscle wasting, cachexia, anemia, dysregulation, this HPA axis dysregulation, neurotransmitter imbalance, because it also affect the neurotransmitter junctions. You understand? That's in terms of muscle coupling and action protein generation, that neurotransmitter that help in excitation. So all those things, are also altered and reduced. So you may even want to push further, but the muscle is not responding. Sleep disturbance, physical deconditioning. So these are the areas that it affects that will now lead to cancer-related fatigue. All these things will reduce ATP production, cause muscle weakness, neuroinflammation, poor oxygen delivery, and cognitive dysfunction. So cancer-related fatigue, exercise training, when you do exercise, I just want to bring about what exercise does to counteract these things. That's summarily before we go to our exercise and all those things that we want to know as physiotherapists. So, cancer-related fatigue, exercise training, during exercise training, you know, exercise training or prescription and cancer-related fatigue. We reduce the chronic inflammation. We have summarily discussed how the inflammation can lead to fatigue. We bring about increased mitochondrial biogenesis, production of new mitochondria. Yes, exercise. That's why, as physiotherapy, this exercise, when we know the molecular aspect of it can enhance our research potentials and inquisitiveness. So that's mitochondrial biogenesis through the PGC1 alpha pathway. So these ones, when you come for further studies, this one you go into the molecular part of it deep. So that this case signaling, to say reduce the inflammatory thing. Then the muscle protein synthesis. Exercise has a way of increasing the muscle protein synthesis. Then antioxidant defense, because this antioxidant defense is important. The exercise increases it through NRF2, system. Because when you put this reactive oxygen, when those reactive oxygen species are reduced, in fact, of course, free radicals, even our body produces free radicals, even during metabolism and all those things. But then our antioxidant pathway in the body can take care of it and remove those free radicals. You understand? Just like germs will enter the body, our strong immune system will attack it. Those germs overwhelm our immune system, then we start coming down with a disease. So now antioxidant defense is boosted so that it can take care of those free active or oxygen species release during these dangerously catabolic processes, in cancer occurrence, So, and cardiovascular efficiency, when these muscle things are restored, mitochondrial energy is produced, and anemia is reduced, then of course, they have increased cardiovascular efficiency. And so it has been shown that sleep quality and the autonomic balance is also increased, and it so reduces physical deconditioning. All these things will improve energy production, muscle function, cognitive function, and energy utilization. This is just in a nutshell. One of all these processes that I highlighted here, if you start to study the pathway, it is very, strong. So all this will reduce cancer-related fatigue. Why exercise works? No. Why exercise works? Exercise is effective because it targets multiple mechanisms simultaneously. You understand? So we have seen in summary, but we bring it to life. Multiple mechanisms, reduce inflammation. Lower pro-inflammatory cytokine, improve mitochondrial function. I've said it, but it's just for listing it here so that when you make reference to the slide, you can get the details well. Enhances ATP production and cellular energy. Yes. So it builds muscle strength and endurance, improves psychological well-being, enhances cardiorespiratory fitness and function. So, what's it improve? The outcome you see: fatigue reduces, physical function improves, quality of life improves, tolerance to treatments, long-term health benefits. Even when the person is in exile, even the person is exercising, it makes the person to tolerate this treatment even better, because those treatment cause a fatigue side effect. But when you're also tackling the fatigue, you can make the person to have the stamina to be able to withstand, the negative impact of cancer treatment. So physiotherapy assessment of cancer-related fatigue. So why do we even assess the assessment of cancer-related fatigue? Just like scientists and clinicians, we know it. We have to confirm presence and familiarity of fatigue. Is that fatigue actually existing? We want to confirm it's existing. If it's existing, at what level? What is the severity? Identify contributing factor. What are the factors that are contributing to? We have seen the multi-system involvement that's are there. Is person having chemotherapy? Is it combined with radiotherapy? Is what stage of cancer? And other things. So detect reversible causes. If there are some causes that can be reversed, then after that, you get individualized intervention, because we must individualize your intervention, exercise intervention. Then you monitor treatment response, because after you have confirmed severity and presence, you start intervention, you have to reassess to monitor treatment response. Establish functional baseline. Also, that should even be the first one to establish functional baseline. So it's subjective and multidimensional. So assessments should combine both patient-reported outcomes with objective functional measurement. So of course, because it's subjective, from our definition, is subjective assessment or subjective reports of tiredness or exhaustion. It's what the patient tells you that it is because that's how you identify. And but there are other systems that are involved, like the muscles. You understand, psychological issues. So when you see a cancer a patient a cancer patient that come down with cancer related fatigue, your interest shouldn't just put exercise and to exercise relieve the fatigue and energy comes back. No, it affects the muscle. We talked about the strength and the endurance. So you have to also assess the muscles of the body, lower limb, upper limb, to sustain the strength of the muscle and the endurance of the muscle. You have to dive into the psychological part. You have to know the anxiety and depression level of the patient. If there's anxiety and depression are there, psychological well-being. You have items, outcome measures that you can. You have to assess the quality of life because cancer-related fatigue affects the quality of life. You have to assess the functional ability of the person because it affects physical function. All these things are baseline data that you should gather so that when you put that exercise, in addition to this fatigue itself and its severity, in addition to that, your treatments must have to be able to affect these components of health, this health aspect, so that the quality of life of the patients which this CRF has affected can be improved as a result of your treatment. If not, it will just be a half treatment you're giving. You may not be getting patient satisfaction, of course. And also, we have to remember the ICF format, of course, activity restriction and participation. So we have to look at it. We should be able to know if the CRF has affected activity participation or social participation, or if they brought about activity restriction and activity and social participation. So in our treatment, we should also look at the ICF, this thing, and also check it along that line. You understand? To make sure that the what restriction both in activity and in participation that the CRF has brought on the patient is also being relieved. That person participates more in activity and also in social participation and activity and participation. So clinical presentation, physical symptoms. You can see persistent tiredness, not relieved by rest, muscle weakness, reduced endurance, exercise intolerance, sleep disturbance. These are physical things. These are questions that you should ask. You understand and get about the sleep disturbances. So ask them. If you want to more, you can use some sleep scale, Peter Boll's sleep scale, and all of that to find out those things. So you have to look at this cognitive symptom, poor concentration. You have to ask about the person concentration level, memory impairment, whether there's any effect on the person memory, reduced attention, and slowed thinking. You must have to probe and ask because this sometimes becomes more concerning to the patients more than the physical symptoms. When they have slow thinking, poor concentration, memory impairment, and reduced attention, this sometimes becomes more impacting and more concerning to the patient. And those aspects we have to also be looked at and make sure that it's also improved alongside your exercise and this area of research in oncology. So behavioral symptom, reduced physical activity, social withdrawal changes in lifestyle habit. That is when we talk about that ICF. You should make sure that it's tailored down. You also get result in behavioral symptom. So there is increased physical activity performance and performance on activities of daily living and also participation in social participation because social withdrawal will bring about activity restriction and participation restriction. Then there's changes in life after the person starts gradually building exercise into the person's lifestyle and also good nutrition as as time goes on. So what are the factors contributing to this cancer-related fatigue? Of course, disease related, we have said it. Cancer progression, cachexia itself, as a result of the cancer progression and also inflammatory process and as a result of the radiation therapy that brain, releases all those free radicals in the body. Pain and inflammation, all these things limit as a result of the disease. So the pain and inflammation, can lead to cancer-related fatigue. Treatment-related chemotherapy, radiotherapy, surgery, hormonal therapy, immunotherapy, we have discussed them, how they affect it. Psychological anemia, physiological, sorry, anemia, infection, malnutrition, dehydration, metabolic changes, all of them. Imagine a cancer patient, we are talking of protein catabolism, we are talking of oxidative stress, And we're talking at high energy demand, catabolic effect, dangerously catabolic effect of cancer cells itself are divided, demanding high levels of energy and exothermic reactions here and there, and sapping the carbohydrate content of and stores of the body and resorting to protein catabolic. The person is now malnourished, is not doing balanced diet, and or is dehydrated, not taking enough water, all those things. You understand? So you see, it can enhance the physiological, exacerbate the physiological response that may lead to cancer-related fatigue. That is why in the oncology multidisciplinary team, we have oncology, nutrition, and dietetists. Like what we have oncology nurse, pharmacists, psychologists, we consult psycho-oncology. That nutritionist and dietetics person takes care of the nutrition of the guy because they understand this metabolic pathway and know what may actually be going on. So if you want to use only exercise to restore check on nutrition, you will not. It's in combination. So psychological, anxiety, depression, and stress, then lifestyle, physical inactivity, poor sleep, inadequate nutrition, sedentary behavior. These are contributory factors. Remember when we say in assessment, you also find out contributory factors and know those factors that can be reversible. Like lifestyle factors can be reversible. Physiological factors, to a great extent, can be reversible. Psychological can be reversible. But the treatment and disease, you may not reverse them, but you can attenuate. Because as long as the treatment happens, those things must be there. So ICM framework for physiotherapy assessments, as we mentioned, we have to give it a health condition, cancer, body functions, as we structure fatigue severity, muscle strength, pain. So fatigue severity, well, it's the health condition is the cancer. So it which affect the body functions and structures, where you see weakness of muscle, reduced cardiopulmonary endurance, that's aerobic capacity, and all those things. What you see, fatigue, it will lead to degree of fatigue and its severity. The degree of affectation of the body parts will determine the level of fatigue that you have. The muscle strength will be affected, pain and range of motion, balance and sleep quality. So this is what you should assess, to rate up for the consequences of body function affectation. And those things we need to activities, walking, stay climbing, cease to stand, transfer activities of daily living. You have to ask, it's a physical activity level, walking, even climbing, staying, doing little things that's requires a little bit of more energy. You can do sit to stand exercise, to load the lower muscles. These are simple things that to your surprise, it's become difficult in this set of patients. Of course, when we're coming to that, and transfers and activities of daily living. So participation in employment, how has that affected employment? Is the person meeting up with work demand? Family rules, how has it impacted on the family rules? We have discussed that a bit. Social activities, can the person be able to, you know, go out for social activity and recreation and be able to navigate his path, or, and also, that kind of thing, and other things. So that's where we now look at the home environment, social support, motivation, and treatment status. These are contextual factors because we have to look at home environment. What is it in the home environment? Social support the person is getting, the motivation the person is getting, and the treatment status of the person. So subjective assessment will now come. What are the subjective assessment that we do? Fatigue history. These are the things that you ask. You have to ask about their fatigue. We know all this is, but we must mention it as because we are presenting. Fatigue history, the onset, the duration, the severity, the pattern, what aggravates it, and what make you feel better. Pattern. Is it in the morning, afternoon, night? Relieving factors, medical history, cancer diagnosis. What cancer do you have? What is the stage? What treatments have you really received? Is it chemotherapy, radiotherapy? Is it only chemo, radio, or surgery? Then comorbidity, diabetes, heart disease, renal disease, and medications. What medications are you having? Hypertension. Because some people who are hypertensive and they are with calcium blockers, beta blockers, of course, you see that there will even be postural hypertension, even to get up, the person feel disease when the person uses it prolonged time. It can also compound, and make the person to be more deconditioned because the person will be mobilized more. Even when you want to mobilize the person, it becomes difficult unless those beta blockers are reduced from the person's medications. If not, as the person wants to, that beta blockers brings about hypotension on the long run. so which may impact rehabilitation. So medications, you also look at medication. If there's a neuronal issue, muscle license and all those things, there are other things that you should look at that may be contributing or compounding the fatigue. Functional history, mobility, activities of the day, may work and study, of course, exercise history, daily routine, how has it? Because these areas, your treatment must impact them. You must address to them and know that, make sure that it gets has positive impact, that improvements in all these parts, all these aspects of health. So red flags, we're talking about assessments. We are leading to those should lead to exercise. When you have fever, you shouldn't be thinking of any exercise until sudden severe fatigue, chest pain, new neurological symptom, unexplained waist loss. So objective physiotherapy assessment. Of course, we have to also have that ICF in mind, and also what's other things that we have discussed. In muscle function, as long as big as hand grip, strength, manual muscle testing to determine the power, sit to stand, yes, and especially in the elderly, dynamometry, you have to do all those things. Functional capacity, to know how affectation of the body functions. You have to superimpose the ICF on this affectation of body function. One of the person is muscle, another one is cardiorespiratory. All those things has affected the performance, body performance, functional capacity. 6 minute walk test. You now know, what the person is able to achieve. You now predict. So incremental shuttle walk test in person, if it is early diagnosed, when the person still have strength, not when disease has progressed to late palliation and hospice stage. Time up and go test. These are good even for the elderly. So physical performance, you get speed, balance, simple straight leg, single leg stand. You can use it, and other small walking, placing the heel in front of the foot, walking on a straight line. All those little things, stair climbing and functional reach to take physical performance. Cardiopulmonary response, heart rate, blood pressure, oxygen saturation, bulk rate of passive exertion and during activity. Then discipline, if there's breathlessness, which also a very strong debilitating symptom that they have. And when you have discipline and difficulty in breathing, it will lead to breathlessness. Of course, using apical chest zones, accessory muscles of respiration, particularly the mastoid, the breathing becomes shallow, oxygen is not entering, and carbon dioxide is accumulating. And the chemoreceptor centers are activated, which responds by increasing the respiratory rate to know if this carbon dioxide can be expired. But they're not achieving anything because the breathing is shadow and the pattern. So you need to break the pattern of discipline in this if you must actually make headway in the treatment of addressing fatigue, because the body needs energy. So other measures that we check is sleep quality, pain, nutritional status. You can engage with the nutrition and dietetics, and the mood. Um, uh, Hospital anxiety depression scale. You can use it. It's just very fast in the clinical setting. Hospital anxiety depression scale to check mood. That's looking at an psychological issue. So, but there are some validated fatigue assessments which you can look up, which you can use. But this one, I will tell you the strengths of each one, like brief fatigue inventory. It can give you the severity and the impact of the fatigue. You understand? You give you the severity and its interference to activity, different type of activity. But it's very fast because just 2 to 3 minutes, like a busy clinic session, just for screening and routine practice. You can use it for routine practice and for screening to know the person has fatigue. Then, if the person has fatigue, you can now look more. Start all those muscle testing, aerobic endurance testing, all those things, RLM, pain, and all of that. To know to make sure that all the aspects of health that fatigue affect is multifactorial affect. That's how it has impacted on those, and how you can address those aspects of health and domains. Then fatigue scale. This fatigue related quality of life in cancer. It's validated in cancer, used for cancer, and maybe using it now for one of my clinical research. So it's for clinical practice and for research. It's deeper, it's deeper. But for just routine one that is fast in the clinical business, brief fatigue scale is good. Then paper fatigue scale is multidimensional. It's a behavioral, affective, ancestry, and cognition. it delves into the psychological. So you can have a combination when you want to get all the components out, the psychological and behavioral. You can combine Piper and Green fatigue or Piper and facet fatigue scale. So it's comprehensive assessment. You really need to take your time to do it. Then we have European Quality of Life, see that cancer specific fatigue. It's we have Euroqual 5D3L, 5D5L. There are many. So oncology clinical trials is used for oncology, but we also use it for research. So we have multiple symptoms. This SR, of course, so it's used for palliative care and advanced cancer. So you use that SSR, when you want to assess this fatigue in palliative care and advanced cancer. We also have to talk about exercise in palliative care and hospice. So these are some of the things you can look up. You can use it to, whether it's for practice, whether it's for research, it's used for address cancer. After addressing all those physical, interference, physical activity, psychological domain, make sure we also remember that we have some objective assessments to determine its impact on body function, which has reduced activity limitation and participation restriction to conform to ICF. So apart from all these patient reports, this is the subjective part of it because fatigue is a subjective report of the patient. We have to also, because it goes beyond the subjective, affecting the body structures and functions. So we have to assess the body structures and also functions to know how it's affected them so that we also give them attention. So clinical assessment, all give them, you see the cancer patient, you ask about fatigue. Have you been feeling unusually tired or exhausted? You ask, the patient says no. So then routine review, continue monitoring, nothing happens. When the person comes again, you ask the question. But when you ask about fatigue, say yes, there's fatigue present. Then you now use BFL and this can brief fatigue inventory. You use it to investigate. So you identify contributing factors, medical, psychological, and lifestyle. When you have investigated and say there's fatigue, you now have to ask questions to also bring about the medical, psychological, and lifestyle factors. Issues like chemotherapy, drug, medications, or treatment the person has received, anxiety, depressions, all these psychological and also lifestyle factors like nutrition status or nutrition habits and physical activity habits of the person. You understand? So that is physiotherapy assessment, subjective and objective. You understand? In addition to assessing the body functions, then you now have individualized intervention like exercise, education, self-management. Then you are reassess and monitor progress, as you treat and move. So from this now, the take homes from this is that cancer, the CRF is multidimensional and highly individualized. So assessment should be comprehensive and patient-centered. Combine patient report outcome with objective functional measures. Use the ICF framework to guide assessment across all domains. Assessment findings should directly inform individualized physiotherapy care. In cancer care, CRF is the sixth vital sign. Cancer-related fatigue in oncology setting, if you practice there, always assess for it. Is the sixth vital sign in oncology rehabilitation. When you have assessed for every other thing, you have to assess for CRF. It's one of your vital signs. So we go to exercise prescription. So exercise prescription. Hello, please. I don't know. I hope I'm audible.
Yes, we can hear you.
How
Yes, we're
much
hearing
audio?
you.
Okay, so we go to principles of exercise prescription. So of course, we know this, but we have to mention it because we have to build on something before we progress. Individualized, it must be individualized, specific, progressive, safe, sustainable, and patient-centered. So you tailor exercise to patient's health status, cancer type, treatment phase, goals you have set, and preferences of the patient. Because please mute yourself, please. So when I'm talking about individualization, not only individualization to patient health status or cancer type or treatment phase or goal set, but also to preferences of the patient because you set goals with the patient. You may want the patient to be able to walk 20 meters, maybe in a treatment session. The patient tells you that he doesn't need to go, that all he wants is that to walk independently and enter the daughter's wedding and come out. You see, if you set that goal without consulting the patient, you set your own, patient will not cooperate. Adherence to anything you are giving to him, you will see it as being laborious. So you have to individualize it, with the goals and preferences of patients. You set the goals together and also know which exercise and what the patient also prefer. Does he prefer group exercise? Does he prefer home exercise? Does he prefer, single clinic exercise? Personalized, just one-on-one. So specific, your target identified impairments. From all our assessment, what we will do after assessment, there's no how you have not targeted some impairment, whether it's fatigue, weakness, low endurance, reduced function, reduced participation, whatever. You have to be specific so that you know what you are administering and what you are targeting and what you want to achieve. So you progress gradually, increase duration, intensity, or resistance gradually as tolerated. It cannot be the same thing for everyone. So you increase one at a time. You don't increase duration and intensity. You might start to increase the duration before intensity, or intensity before the duration, or before you keep maneuvering it. So you have to consider the medical status, treatment side effects, contraindication, and precaution. Of course, when somebody takes chemotherapy for the next 3 days or 1 week, you will not do anything exercise, all those things, except all those breathing exercise or movement of the limbs because of the impact of the chemotherapy, acute impact of chemotherapy, the side effects. Because you know that it's attack the immune system and lower the immune system greatly. So that's why some people they don't even complete their regimens of chemotherapy because when they assess the immune system, their level it will get. If you give another one, the person will just die. The immune system will not even be able to sustain the person. So they just quit even when the person has not completed the regimen of chemotherapy. So we have to consider the safety. So don't be overzealous. Consider medical status of the person, treatment side effect, contraindications and precautions. We also have to talk about some contraindication. So we have to make it sustainable, promote long-term adherence and lifestyle changes. So anything that you do, let it be what you know that it will be what should be integrated in the person's life because we won't, well, if the person is not in survivorship stage, the person will also enter the survivorship stage where you're living for months and years. So it will not be like the normal conventional research that we just perform it in the clinic or in this research lab, and then in the community at the community level, it's not integrated. And you're also looking for ways of integrating them. So we have to start looking at thinking about integration right from the inception. So we have to be patient-centered, have both good setting of goal and decision making. I was talked about it. So components of exercise program, aerobic training, resistance training, flexibility training, and mind and body exercise also comes in. So aerobic training improves cardiorespiratory fitness, reduces fatigue, and enhances and endurance. You see, in this what we listed, we didn't really start saying or jogging. You understand? Just simple walking, can be brisk, cycling, swimming, elliptical training. Know that elliptical bicycle where you just sit down and relax your back. Not the one, you have to give comfort position and relaxation. Low impact dancing. These are some of the aerobic things that you do. Not really too much vigorous things. All those things. So resistance training resistance training increases the muscle strength, preserves lean muscle mass, especially in cachexia, which you treat alongside dietary inputs and improve functional capacity. So this is what resistance training do. You see, you use resistance band, weight machines, body weight exercises, and functional strengthening. And we prefer resistance band and body weight exercises. Weight machines, of course, you have to be very, very careful. If there's metastasis to the bones, it's fragile that even weight machines and all those dumbbell can fracture the bone. So we use resistant band. I know this resistant band or elastic band has different colors that corresponds to different resistances. The person can pull all upper limb and lower limb and all those things. So you can use body weight exercise, using body movement against the weight of the body, like curl up. The abdominal muscle will be pulling up the trunk and the force of gravity. Straight leg raise, it will be pulling up the hip flexors, will be pulling up the bone of the lower limb plus the force of gravity. Press up, all those things are body weight exercises. They are safer with resistant band. in resistant training, and it works a lot in this kind of people and in hematological cancer in particular. So flexibility training, of course, you do flexibility exercise to the body parts that you want to before you do flexibility exercise. Especially, you have to must do it as a part of warm up to the body part that you want to strengthen. So static stretching, dynamic stretching, range of motion exercises, and mobility exercises before you start the main aerobic and resistant exercise. So mind and body exercise is good. Mind and body exercises reduces stress, improves mood, enhances sleep, and overall well-being. Yes, research are proving it because it's a way, it has a way of endogenous all these neurotransmitters, stress relieving hormones. Yoga, tai chi, wing chun, breathing exercises, mindful meditation, breathing exercises. There, all of you can do it. But yoga, tai chi, wing chun, you ching kong, you need a training to do it. One physiotherapist did it in PhD. He learned this, and it's very very effective. It relieves stress among students. So exercise prescription, you use that fit and volume principle. Frequency for aerobic exercise, the person must have to walk, cycle all those in 3 to 5 days per week. Then resistance training is 2 to 3 days per week. Of course, you know that interspace aerobic exercise with resistance exercise. When the person does resistance exercise, the person will stay 2 days or another day before he now does the second one. So flexibility and mind body exercise daily or most time of the day. But of course, you know that when you start, we say 3 to 5. That is what you want to achieve, not what you will start with. So that's why we say it must be individualized. If the person can only do once in a day, no problem. Even if he cannot meet up to 20 minutes, you understand? Can say 5 minutes in the morning, 5 minutes after, it's only one day, no problem. But the thing that let it be progressive because you must individualize it, look at the medical status of the person, look at the treatment status, look at the stage of the cancer, and look at the stamina of the patient. Intensity, moderate intensity, 40 to 70% heart rate reserve, above rate of passive exertion when it's at level 10, 11 to 13, light to somehow somewhat hard when the person is working. If the person can be talking to themselves, when patient education is key. So we encourage when the person is exercising, doing that, working, swimming, or whatever. Person is speaking to a partner or speaking. When you find it hard, somehow hard, that means at that level, the person hates it. You should not exercise beyond it. So heart rate reserve, it has a formula to calculate it. So in your cardiopulmonary physiotherapy, you would have been taught that. So when you calculate it, you will not know the heart rate level person will exercise within, so that the person has reached that moderate intensity level. So with the formula, it has some constant. If you calculate it, 40% to 70% of it. It's not maximum heart rate. Oh, that one is 220 220 minus age. You find 40, and it's not. This one is heart rate reserve formula. It's better than maximum heart rate formula. So when we find for 40, maybe 40, we say the heart rate will be 60, 70 a day is 120. So the person target is to exercise within 60, so 120 heart rate. But as he's doing exercise, he monitors it. If he exceeds that 120, it should not exceed. Once it gets 120, the person should terminate the exercise. So if it is 60, that does not mean the person must not get to that. It might just do, and the heart rate increase to 25. No problem. The person gets that. It's a gradual process you build into it to get that intensity. So 20 to 60 minutes, something goes. You must not get to that 20 minutes. So the thing is that you keep building and resistance exercise 1 to 3 sets of 18 to 15 repetition. You manipulate distance on the person until the person gets to this target, and also flexibility. You understand? So the type, it can be aerobic, it can be resistance, it can be flexibility, and man and body. You can do this whole package depending on the tolerance and stamina of the patient. You can do flexibility exercise and patient gets no problem. Tomorrow he does flexibility, no problem. Next tomorrow no problem. From there he start getting stamina to do mind aerobic, mind and body exercise. All those things. So you now increase the volume. You progress gradually based on tolerance and goals, as we have said, and progression increase one variable at a time. That's why I say you can only increase the duration or the intensity at a time. When you get one, before you don't increase the duration and intensity at the same time, you just build that special set of patients. So exercise prescription by treatment phase, Of course, we have prehabilitation, pre-treatment before the person starts treatment, be it surgery, be it chemotherapy, radiotherapy, immunotherapy, so on and so forth. During active treatment, post-treatment, after treatment, that means the person has completed the treatment, is now in survivorship or advanced cancer or palliative care. So pre-treatment rehabilitation, build what you're facing is to build fitness, because that one is almost at diagnosis, especially when it's diagnosis early. You build fitness even before the person start treatment, improve strength, enhance resilience, and educate and prepare the patient before the patient enters treatment. In most centers, you don't see this, but I'm encouraging you to make a case for that, so that as much as you can, you build the fitness level of the muscle of that person, both muscle wise and cardiopulmonary wise, and improve strength. You understand? Before the person now enter the treatment, because when the person enter treatment, you're not building any treatment, so you're just going to maintain the function that is there to preserve it and to reduce fatigue, because you have another challenge of tackling the side effects of the treatment, which is also debilitating and enormous. Also minimizing the conditioning and manage symptoms safely. That is what the challenge you face in that during active treatment. If you don't manage those symptoms that arise as a result of the cancer treatment, ah, man, it's too much. That can become a disease on its own. So, but then, because cancer treatment prolongs life, it is like as an advantage, it outweighs this negative impact of the cancer treatment, the symptoms, the effects, negative effect of the cancer treatment. Then, post treatment intervention, you now restore the fitness that you built in the pre treatment level that may be lost to an extent during active treatment, because you cannot do with the density and volume you do pre-treatment, in pre-treatment in active. So now when the person has completed treatment, you try to restore that fitness level. That's why education and prepare. You prepare the patient. You would have told the patients also these stages. So you know that after treatments, we must have to build to come back to what it was before you enter treatment, improve body composition and enhance quality of life, promote return to rules. The person need to return to role, return to work, return to activity and all those things. Then in advanced cancer and palliative care, your own at this level, nobody's talking about curative treatment. It's just comfort care. You symptom relief, all those symptoms. You maintain mobility, prevent complete complication, and improve quality of life. You are not restoring any fitness. You are not improving any body composition. You're not promoting return to rules like in the post treatment. We can only the only thing that is common among them is improving quality of life or enhancing quality of life. So, for instance, if you have a restricted range of motion in palliative care advanced cancer at the elbow, and you want to do ROM to improve that range, which is good, and you want to do it and it's causing pain, you stop it. Don't improve that range. That is the principle of palliative care. You leave it within that range, but you have to do ROM exercise within that permissible range so that it cannot be reduced the more. And adhesion and stiffness will not. It's all about comfort care. Those people are within 1 year. Some have prognosis of 6 months or less. So you are just maintaining their dignity, maintaining comfort, positioning, anti-constructive positioning, positioning to relieve pressure sore. Breathing exercises, you don't even give the complete set of big names like you do chest expansion exercise, diaphragmatic exercise, and all those things. It may not have the stamina to do it. Even if there's excretion, because cancer has gone to the lung metastasis, or even cancer originating from the lungs, even huffing and coughing will be difficult for such person, and that's late stages. That's why one of the things they teach is autogenic drainage, the one that the person does on his own mildly, even before the person gets to that stage. You prepare the person autogenic drainage to get out those things. So in advance, whatever exercise you are doing, you are not concerned about this thing we say there. Where is it? This intensity, 40 to 75% heart rate maximum, repetitive maximum. No, all those things are gone. The exercise is just to relieve function, maintain mobility within the limitation already placed on the patient by the disease. You're not improving anything. Anything is going to improve that will be strenuous, cause pain to the patient. No, you're not returning the patient to any role. It's just doing things to make the person relax and do and feel good. Those are exercises that you do at palliative and hospice level. So now, example of exercise prescriptions, we go further. An aerobic exercise that we mentioned, mode, walking, cycling, swimming, intensity. You see it's 40 to 70 burst rate frequency. The same thing for resistance. I cannot go to mention it. We have talked about it, but it's just to make it even flexibility. The what you do there, and how many times time, mind and body. This is just going deeper. This is just a template. You must not adhere to this. You individualize. You build gradually and into this. Even at hospice level or late palliation, you may not even get into this, but at least you do something that will refresh the patients and still bring relaxation and comfort to the person. So safety consideration and contraindication. So when you say safety consideration, obtain medical clearance before you do, because you must have to work with oncologists. If you're not working with oncologists, develop that attitude. This spare or this sort of care is not. If you do cancer care as a physiotherapist, then you won't enjoy it. Oh. You can only enjoy it when you work with other teams. Try it, you see. You can enjoy it. It's a lot of teamwork, and everybody appreciates each other. You screen for red flags and symptoms. The motor vital sign is perceived rate of exertion and symptoms. You modify for treatment side effects when there's anemia, neuropathy, lymphedema, bone metastasis. You modify, you can defer or you modify. Ensure hydration and nutrition. You stop exercise if adverse effects happen. But outright or absolute contraindication when there's unstable cardiovascular condition or sudden chest pain, uncontrolled infection. You understand? You see there's an infection, the pressure is increasing, white blood cell count is increasing because you have to be looking at the medical chart. You have to don't need to do any exercise. When there's severe anemia, that the hemoglobin is lower than 8 gram per day, you do nothing. When there's severe thrombocytopenia, of course, platelet level is below 20,000 microliters. So this thrombocytopenia is very, very important because it's a clotting issue. So if they will not have platelets, not only that you don't do exercise, even when the platelets level is not below 20,000 microliter, but it is not within the normal range, but has not diminished or declined to this level, you should take precautions. Anything that involves deep massage, you understand? Anything that it will involve friction, maybe you are trying to straighten, tighten tendon as a result of surgery and all those things. Nah, because any micro trauma can lead to internal bleeding or any high impact exercise like in bone metastasis that causes all these pathological factors can lead to bleeding inside and you will not know it. It will lead to death. Then spinal cord compression. When there's spinal cord compression, you stop. But sometimes you have to assess the level. Spinal instability test. You understand? When you do it, assess for it. There's this spinal instability test score that you assess it when you get the score. Of course, we are trying to give a summary of these things. There are many aspects of this lecture that even requires a full time attention and lecture, like this one I'm talking about. Now, when you now get the score, you will now know whether you are stopping the treatments, physiotherapy treatment exercise completely, or whether you are applying bracing to continue, or whether you are applying bracing and make sure that whatever you are doing will not be in a position that you put load on the spine. But the score that you get from the assessment when you have spinal cord compression will now determine. But to be honest, first, if you don't have the skill to do that assessment, if you use spinal cord compression, I think you just have to stop anything exercise and refer to your seniors. Pathological fracture risk, if it is there, or maybe another lecture, one can now talk deep into that. So monitoring and outcome measure, fatigue severity, you monitor it, functional capacity, you monitor muscle strength, exercise tolerance, pain and dyspnea, balance and mobility, sleep and quality of life. These are areas that you monitor to you must have to reassess every 4 to 6 weeks and adjust the program based on progress, treatment changes, and new goals that you have set to yourself. Then program progression strategy, baseline assessment. Yet you set goals, short-term and long-term goal with the patient. You implement exercise plan. You monitor and reassess every 4 weeks. Then you progress the program. You now adjust. When you have achieved your goal, you know, I set new set of goal for the next 4 weeks or 6 weeks. So at the end of that week, you reassess. If it has not been achieved, you ask question, why has it not been achieved? There are these things were called reflecting in action and reflecting on action. Reflecting in action, that time, that thing you are doing, that exercises you are prescribing, you reflect, could it be anything better than that? You understand? Then reflecting on, we now assess all we've been doing to see could there have been any better theory or anything, that would have made it, that kind of thing. You reflect in on action, that when you do not achieve the goal. Even when achieving the goal, you just have to continue reflecting. That is the open-mindedness of a clinician. So that in your reflection, you can, or that means you are making yourself open. Even when a younger colleagues now comes in, yes, you can accept and now reflect. And now, so as clinicians, we are not very, very certain. We are talking, we are talking, we go by probability. The chances of this treatment being effective, that kind of thing. Not that we are sure that it will work. Something will make it not work, depending. So key take home, exercise is safe, effective, and is the first line non-pharmacological treatment for CRF. A combination of aerobic resistance, flexibility, and mind-body exercise is ideal. Use the FIT BP principle to individualize and progress exercise safety. Program must be patient-centered, feasible, and sustainable. Regular monitoring and appropriate progression minimizes benefits and minimizes risk. Remember to start low, go slow, but keep moving. There's something I want us to look at: fatigue management in hospice and palliative care. So we have said in oncology, but then you know that when people have started progressing to, we have early palliation, late palliation, and hospice. So of course, hospice is part of is within palliative care. So if prognosis has been limited to equal to 1 year or less than 1 year, the person has entered late palliation. If the prognosis has now shortened, been limited to 6 months or less, it's progressive. That person just have 6 months or less to live, or person, it's hospice. So now at that level, anything curative treatment or intervention is shut down. It's comfort care that palliative care is concerned with, even physiotherapy. So exercise in this kind of people may not follow strictly all those things we listed, 40 to 70% heart rate reserve and all of that. It may be burdensome. So what we are doing is comfort care, and it's stratified in stages. So when you get such person, there are a lot of symptoms that you may see. Apart from fatigue, you may see breathlessness will be there and other things. Immediate comfort is what you have to achieve first. If you don't get immediate comfort, whatever you do, the patient may not have the stamina or the energy level to do it. So you make sure the positioning is good for ease of breathing. Of course, this patient, when they lie down, always there are difficulty in breathing. So even if person is going to lie down, the head of the bed need to prop up or use pillows at home. Or upright sitting reduces respiratory fatigue. Upright sitting, yes. So a person sits and bends forward and leans on a pillow and soften. Soft cushion prevents postural strain. So you make sure that the person where the person is sitting, where the person is lying, everything about all those things. There's no strain on the body structure. You can use support cushion and make the person comfortable. Then you use breathing techniques, diaphragmatic breathing, that deep breathing exercise, as much as the person can tolerate it, or pulsely breathing. These two only to break the breathlessness that is there. By the time the person is using the intercostal, the accessory muscles of respiration, and you introduce the deep breathing exercise, that diaphragmatic breathing, or you use this diaphragmatic breathing and pulsely breathing. These are the two things that you use to break breathlessness, that use of apical, the accessory muscles of breathing. You understand? And introduce normal breathing pattern as much as you can. And this enhances oxygenation and reduces exertion, even that level of breathing. Therefore, it will increase respiratory efficiency. And once more oxygen gets into the body, at least you can see the catastrophic effect of cancer and its treatment and other things in destroying the DNA and the mitochondria and the ATP production. At least let us have enough oxygen for the little energy and little mitochondria that is reserved to carry out metabolic activities to reduce ATP, which is the energy that the body needs. When you do gentle arrow exercise daily to prevent stiffness and contraction, which Contractures and all those things can lead to abnormal body part positioning and strain on the body, and also energy demand increases. So anything that will cause strain or pain, you do so prevent it. If it is already there, you're not going to stretch to cause pain to relieve it. No, it's a position of discomfort. Everything you're going to do is to restore immediate comfort. By the time you have broken that breathless into some level and restore comfort by positioning, and the oxygen is there, and at least the person gets realized, you can now start to do functional relaxation, low intensity activity, like gentle stretching. Of course, you see in our activity, when we are talking about aerobic in that cancer that we talked about, which is not in hospice or so we are taking walking, swimming, bicycling. When we say recumbent bicycling, all those things that we did, even though we didn't put jogging. But now we are not even listing walking. Walking around may not be of interest to the patients because of the fatigue and all those things. Gentle stretching on bed is enough. Chair exercises where the person sits on chair and lifts one leg up and down, and the other one, alternatively, hitting the leg on the floor, putting the 2 feet on the ground, doing ample curl, dorsiflexion and down, raising the heel, bringing the knee together and wide apart, bringing the knee together wide apart. Simple things like that. Reaching out and coming back, reaching out and coming back. The person may engage in short walks just around the house with slow progression. Then you now start teaching energy conservation education, activity rest cycle. So when you now do activity, you break activities. You must rest between activity. You must not get fatigued before you rest. You rest between activities. If you want to cook, maybe there's not a person to help you. You can cut vegetables and keep. You can open the Maggi and all those things and prepare the recipes and put. You boil water, you go and rest. When you do one, you go and rest one. When you want to get things to the chef, you break it to the table before you carry up, all those things. You wash your clothes in bits if you don't have washing machine, or you simplify the task. You want to bed, you sit down instead of bending to pour water on your body or standing under the shower. You sit. You can put rails along the environmental modification. All these are energy conservation techniques, and balance and connection training. Mind standing and seated exercises, and you shift weight from side to side. The weight of the trunk. It's a lot of balance exercise. We are not doing balance that you stand up, start to put your foot in front of your hair and walk in a straight line, or a single leg stance. No, as long small as putting, shifting the trunk. It's a lot of balance, and you are tipping the person forward, backward, left and right, and the person is trying to control the trunk. You understand? So you have to do that. Neuromuscular stimulation. You have to prevent muscle atrophy. We talked about cachexia alongside nutrition, because you can do it alone. That's why on purpose, even when the atrophy has not been much noticed, you start to isolate some muscle parts and stimulate them. You can be stimulating the quadriceps and the hamstrings to increase the strength of the lower muscle in standing and in walking. That kind of thing. So that is the target. You just single them out and stimulate them. Make sure you maintain the body. It is done in oncology practice. you know. Then the long-term observation. After you've done this, you can now come to resistance band body weight. If the person can, maybe smiled, straight leg raise, you know, bring your trunk up a bit down, resistance band, you use the lowest resistance depending on the level of the patient. All these are the resistance thing you're going to do, and these repetitions. So aerobic condition, gentle walking, if the person has improved, if not improved, no problem, or cycling. But this is when the person has improved so much, gradually increasing. Then one after the gentle massage, menstrual release, lymphatic drainage to improve circulation. Yes, when there's lymphedema, that is another topic. I think the next person will do it because it also has effect. It's directly related to fatigue. Fatigue during lymphedema is very high. So it's a risk factor to fatigue, lymphedema. So you can use hydrotherapy for so that you won't do buoyancy, lift up the weight. There's won't be high impact. So this is where I will bring it. All this is just trying to summarize because this is very vast. When they say cancer-related fatigue, it's simple, but it's very enormous and it's very vast, and it needs good attention and the concentration to get it right. So thank you. This is the end of the lecture, and these are part of the references, a lot of them that I used in preparation of this work. So thank you very much. And this is where I will stop and see for comments, corrections, and questions. Thank you. I hope I did not take much of your time.
Thank you very much, Dr. Davidson. This presentation was well loaded, and we really appreciate your time and your efforts. I know that everybody will learn a lot. So now we are opening the floor for questions. Okay, I think people are